right, so we're going to continue the conversation where Arjuna left off and talking about some of the root causes and really addressing what this means for equitable health care for women of color within New Jersey and in regards to maternal and infant health.
You don't have a question prepared for her?
So I'm going to start by, so these lovely individuals on this panel, they have very robust, that's my word for the day, robust. They have very robust bios, and so, but I'm going to give you like the 2-minute elevator bio. And if you would like to further the conversation with them, I encourage you to corner them. No, I'm just joking. To corner them and to ask questions, right? Because that's the best way to learn is by asking questions. All right. So I'm going to start with Alaina. Broach is the founder of Ahava Doula Services and co-founder of Mercer County Birth and Breastfeeding Collective, located in Trenton, New Jersey. Ahava Doula Services provides community-based doula support, childbirth education, breastfeeding mentoring, and a fatherhood enrichment to families of color in Trenton and Mercer County, New Jersey. Alaina works in partnership with her husband, Minister Jared Broach, who is the director of Ahava Fatherhood Program. Together they have 4 children, 3 boys and a girl, who are all born at home with midwives. Can we welcome her to the panel? Next we have Midwife Extraordinaire. I'm giving you that title, that's the title I'm giving. Edith Izzy, and so we did hear her bio earlier, so I'm just going to give you a quick snippet. She is a certified nurse midwife who works at a teaching hospital and was appointed to the School of Midwifery. And she works tirelessly in advocacy for pregnant and parenting parents. And so let's welcome her to our lovely panel. Next we have Nastassia Davis is a registered nurse, international board certified lactation consultant, mother of 4, and resident of West Orange. She has over 13 years of experience working with mothers and babies. Nastassia is passionate about improving access to qualified lactation professionals and improving breastfeeding rates in African American communities. She is the owner of the Latch Breastfeeding and Lactation Services, a private lactation practice offering home and office visits throughout the state. Recently founded the Perinatal Health Equity Foundation, which is a nonprofit dedicated to decreasing racial disparities in maternal and infant health. And she received her bachelor's degree from the College of New Rochelle. She has a master's of science in nursing from Mercy College and is a certified maternal newborn health, and will be completing her doctorate of nursing practice and educational leadership this fall. Can we give her a round of applause, please? Next, we have Rachel Jean Miles. Rachel Jean is a community doula with SPAN's IPO Community Doula Project, and in that role has been serving communities in Essex County since 2017. Rachel is a former teacher and completed her master's in education from Brooklyn College in 1998. She obtained her bachelor's of science in psychology from Stony Brook University in 96, and in 2000, Rachel was honored with her exemplary work in creating a passion for science for her students. Today, Rachel is fully immersed and committed to being a community doula serving women in her community. Can we welcome her, please? Next, we have Dr. Montrae Calhoun Thomas. Okay, now. Is an established and highly skilled physician with over 40 years of experience as a pediatrician. She attended medical school right here in New Jersey at UMDNJ and is a fellow of the American Academy of Pediatrics. She is highly regarded in her community and has received several awards, including recognition as one of New Jersey's favorite kids doctors. That's come on now. For kids to like you, that means you're doing a good job. And has also been a recipient of the NAACP of the Oranges and Maplewood Lifetime Achievement Award. Her dedication to community is evidenced by her service to her community. Can we welcome her, please? Okay, so we've heard this evening a lot about the infant and maternal mortality and some of the many various different ways in which women of color, especially Black women, are being affected in some of those disparities. And so, for Nastassia, I have a wonderful question for you.
Okay.
What are some of the challenges facing Black mamas related to maternal health outcomes, and how do you think that may be, or what is the correlation between that and lactation?
Okay. Give her the mic. Okay, so I'm going to use my notes to kind of just keep myself on task. I think there are a number of challenges for Black mamas, but the one that comes to the forefront for me is the lack of cultural competency and cultural sensitivity in the care providers that are working in communities of color. What I hear most from my moms is that they don't feel like they are listened to, they don't feel heard, they feel like they are stereotyped from the moment they come in the door. They have told me things like care has been left out for them, appropriate referrals were not made for them. When discussing birth control in particular, Depo-Provera seems to be the method of choice. They're not offered the opportunity to discuss other methods. They're not encouraged to reach their goals sometimes, and often dissuaded from reaching their goals. So they work with a lot of assumptions, and I run a local support group called Sisters Who Breastfeed, and just this week I had a mom explain, share a story with me of when she was pregnant. She was very excited to breastfeed and went into the office to see her OB with that excitement and wanted to learn more about, you know, what she could do. And so the doctor had asked her what were her feeding choices. What did she want to do? Did she want to formula feed or breastfeed? And she said she wanted to breastfeed. And the doctor told her, oh, no, that's not for you. You don't want to do that. And she left the office in tears. And it made her wonder, what is it about my body, about my milk that's not worthy of giving that to my baby? What makes my body different from anyone else's? And so that hurt me to hear that that was her experience. When someone comes to you with such positive energy, of something that they were excited to share with you, and then they're shut down like that, it's hurtful. And so in that sense, we need to talk about implicit bias. It's unconscious, and we all have biases. Everyone does. It's human nature. But I think the difference in being a healthcare provider is you need to take the time to discover what those biases are, recognize them, and then begin the process of removing them from your care. Because if you're not aware of what they are, then you're not conscious of what it is that you're saying and doing and how it's affecting the people that you're caring for. So a woman cannot trust the provider if she does not relate to them, if she feels like she's being judged. And so therefore the information that she's receiving is not going to be trusted, and that's going to leave her to have suboptimal health outcomes. And so we really need to look at training in cultural diversity and making sure that everyone from the janitorial staff all the way up until the chair of OB is trained in cultural competency and working with communities of color, because if you are working with this community, how can you give them what they need if you don't even know who they are? So I think that's one of the biggest factors that the women I work with face, is they don't feel like they're being heard, and that's important.
Thank you. So what I'm hearing and I'm gathering is that Black women are continuously being silenced around their birthing experience and about their bodies when it comes to their reproductive health, and we have forced coercion into family planning. And if we look at the historical connotations of the forced sterilization of women of color, and in general, right, there is a history of Black women not necessarily trusting providers, right, and not finding a safe space and, to be able to parent the way in which that they choose to. And so I guess my next question would be, and this is for Edith, who is a midwife, what kind of care as a midwife do you feel Black mamas need in order to have better maternal health outcomes as a provider and as a midwife who is seeing, you know, a lot of women on a daily basis?
Thank you for your question. Like I mentioned one thing when I was receiving my award, and that is accessibility. Early access to care. Early access to care is very important. The other thing I will mention is affordability. Most of even though they're citizens, they still don't have insurance. The early access to care will bring us to bring the patient to us earlier. We will do the initial OB visit, which incorporates the checking for everything, including whether the patient is anemic. Those things can set a patient. That's a bad maternal care if a patient is anemic and go to delivery with that. There are other histories that we get from the patient when they come earlier. We want to know if this patient had premature births before. We want to use something prevented. We want to give, if we have to give injection that will stop her from getting a premature birth. We want to do things, screening, real screening to prevent infections. We want to, the history also will give us her insight on how her whole family history. And then we have to get that, all those histories together to know how to manage her. Irrespective of that women of color, I noticed from our practice that most of the time we get them late. I have to tell you honest, we get them very late, and there are reasons for that. It's not their own. It's not by their own making. They don't have insurance, even though they are citizens of America. They still don't know where to get the Medicaid. They don't know that we have, like NCHC, we start them with prenatal, presumptive eligibility. Most of our patients of color do not know this, but I know that there are other races. I have to compare here now. I know some race that we also manage. We are in a multicultural area. We have Portuguese, we have Spanish, we have African Americans. I have to say, actually, that ours come late because they don't know. But I tell you, between July and November, we have what we call we have the grant for presumptive eligibility, undocumented. So even a woman who is undocumented have the chances of having her delivery free services up to the end because it's undocumented. So now the African Americans who are citizens have to know that we have presumptive eligibility in our organization. Most of the federal qualified centers have it. We give them a temporary insurance. We'll take every pregnant woman in within a week and two. This is from NCSC. This is in our policy. So when somebody comes in and said, I don't know where to go, so that leaves, we have a big, also, what do they call it? What do you call it? Your group, the group that what do they call your? We have case managers, but we have people who are supposed to be out there. Outreach. Outreach workers are supposed to be telling every woman in the Essex County that we have programs like this. So we here also have to know it. If you have a pregnant woman who says that they don't know where to go, please tell them to come to Newark Community Health Center or any other federal qualified health center, because there is we have policy to get them in, to give them presumptive eligibility as citizens of the country, or if you have legal ones, and the ones that are here undocumented also have a grant, which is around July to November. When it's gone, then we have a problem on that aspect. But we should not have a problem getting patients in early. because it helps us. And then the affordability is what I'm talking about here. So then our own policy in our organization is that we have to have excellent care, qualified care for patients. And that excellency, we have qualified practitioners and qualified MDs. The providers are qualified to know, to examine a patient and know where to address a problem. We have mental health in our organization. We have case managers who are supposed to find out where the patient, I have some patients who are homeless. I've had couples who are homeless. We need to find homes for them. These are all stressful factors that make patients go into premature labor and birth and have and raise our low birth weight and infant mortality rate. These are all around it. So these three factors, we can go on and on and on with these three factors, and then deal with the staff members, how they treat the patients, and it's on our care.
So what I'm basically hearing is that we really need to address accessible resources, right, to the community that meet the intersections of care, that are culturally competent and are really, we're hitting the ground running, right? And so really taking it a step further behind just not what's going on central in these different institutions, but really going out into the community and really talking to the individuals and educating them around what their options are, so that they feel supported within their reproductive health services. Thank you very much. All right, so Rachel, my doula sister, right? As a community doula, what are some of the barriers that you have faced personally in trying to support someone through having bodily autonomy and or being an active participant, maybe in informed decision making within their reproductive health care?
Can you clarify what you mean exactly?
So just in general, so you're going to a birth, right? You're in the labor and delivery room. What are some of the challenges that you would say you as a doula face in terms of being able to support someone through their care?
I got it. Thank you for your question. As a community doula, one of the main things is that we don't get recognized for knowing our body. We don't get recognized for believing in our bodies. So it's very challenging when you're in a room with a mom and you're having a physician tell her you have to stay put when really she would feel better squatting on her knees. It's challenging when you have a nurse who's telling you you're making too much noise.
Oh, yes.
So we've developed systems where I tell them moan. You've taught me that too. And yeah, the main thing is just the system is not so much built for what we're built for. And there has to be a bridge. And we all are working on it right now, but the bridge has to be reinforced. Not like the bridge in Florida, in that Florida University that collapsed. We need a stronger foundation. Mm-hmm. That's one of the main ones.
And so, I mean, and as a community effort, right? Because the community doula is someone who is really meeting them from where they are, not where we expect them to be, right? And so we're meeting them in their homes. We're attending sometimes prenatal appointments with them. Sometimes we're even going to pediatric visits and their 6-week checkup. How do you feel, or maybe you don't feel, do you feel that the doula is being supported in that role from the community? And if not, what are some of the ways in which a doula could be supported?
I feel like as strong as this system has been, as long as this system has been in place, it should be way stronger. Our foundation has a lot of work to continue to do. What was exactly you wanted to know? I'm sorry.
So, I mean, what are some of the ways that you think that a doula could be supported by the community? And when I say community, I mean broad spectrum, right? And so I'm thinking policymakers, I'm thinking about community-based organizations, or maybe there's an ally, right, who's in the room who's saying, wow, like I'm really impacted by the stories that have been told today. What are some of the ways that you think that those individuals are able to support the community-based doula programs and or the community-based doula?
Just earlier today, I had to call one of my fellow doula sisters. I was in a situation where a mom was pushing me outside of my limits. So I called her for support, and she grounded me, and we were able to I was able to finish that task. One of the main things is to listen. My job is, I'm like a human navigation system. Waves, maps has nothing on me because I'm supported, really. Ancient Song, SPAN, my fellow peers, my doulas, everyone that's helping me, you guys are mine. So when I hear what's going on, I can even put it in. Okay, she has this issue, and my navigation is like, okay, let's talk to Rachel. Let's come here and listen to what's going on. So I think that the main support that we would need right now is to listen. Because we're out there, we know what's going on. We're telling you, we need more help.
And so, again, you know, what we're really trying to emphasize is the fact is that you need to listen to Black women, right? You need to listen to our stories. You need to hear us. You need to be actively listening. You need to be an active participant. And even if it hurts, right? Even if it makes you feel uncomfortable, if their stories are still valid and they need to be heard. And there needs to be equitable change around the way in which Black and brown women are being treated within infant and maternal care. And so that leads me to ask the question to Dr. Thomas. You are regarded as the kids providers, right? And so what are some of the strategies you've implemented in your own personal practice to support Black families and children?
Thank you for the question. I'll probably deviate a bit from it because there are some things that I want to say first. I have been in practice for 40 years.
Hi, Dr. Thomas.
All right. I have an implicit bias, I'll tell you that now, and I'm going to put all of you here on task. In the 40 years that I've been in practice, not one doula has been to my office. Shameful. All right?
Interesting.
Now, if you really want to make a wave, stay out of the obstetrician's office, come to the pediatrician's office, and don't wait until the women, our girls, our teenagers. I believe our health begins prenatally. Right? So when the baby comes to the office for the first time, I have an opportunity to talk to the grandparent, the parent, and we work with the baby. We start with teaching breastfeeding, supporting breastfeeding. You want to know what I do in the office? Nastassia's in my office.
Oh, yeah.
All right? She's been there. It's I guess you call it an experiment, but it was something we needed in our office with a lot of breastfeeding moms, young mothers who have no clue. Talk about understanding their bodies. When you have a teenage girl who has no clue what her clitoris looks like, what her vagina looks like, and why she has a ton of hair, and why she has bumps there. She's afraid to look. I can't touch that. Something is wrong. Something is wrong. Now, we have to start in the pediatrician's office. So what I've done is from the time I started practice, and I started back 40 some odd years ago when we were told that women, that girls were what your speaker said, Hottentots and hot. The girls had so many partners and they were sexually active and all of that stuff. So you can't believe anything that they say. But if a Jewish girl comes in and she tells you, in spite of the fact that she has a sexually transmitted infection, that she's never had sex, you have to believe her. So I said, bullshit.
That's my kind of lady.
Now, I have the privilege now of being able to say to the young people when they come into the office, I don't have to use medical terms. I tell them what their body parts are. I use the medical term, and I also use the street term, because if you're talking above the head of a teenager, they're not going to pay any attention. And I try to make parents comfortable. Please don't shy away from your children. If the guys want to know what's going on, talk to them. If the girls want to know, please let them be aware of themselves and know what their body parts are. So you want to know what I've done in the office? What I primarily try to do is respect the moms who come in. Listen to what they're saying. Now, I'm not saying I'm an angel, because there are lots of times when I hear you and I'm saying to myself, where'd you get that foolishness from? Who told you that dumb stuff? It's ignorance teaching ignorance. Let's sit down and have a conversation. I have moms who believe in immunizations and moms who prefer to postpone immunizations, but we have a conversation. You've never been kicked out of my office, and I've never disrespected you in terms of what you need to do. I've advised you that if you're going into certain areas, these are the things that you need to consider.
17 years.
17 years. Okay. So in my primary practice, I try to treat my parents the way I want to be treated and the way I want my children and my grandchildren treated. You will find that when the child is old enough to have a conversation with me, I try to quiet the parent. Please don't answer. Let this little one talk to me, because this is the child who's here, and they have the problem. So let them explain it however long it takes. Sometimes there's a wait, sometimes there's not. So I see myself, the pediatrician, as a resource, because we've tried throughout the 40 years, my staff and I have tried to gather as much information as we possibly can to share. We do not only preventive care, acute care. We talked about the navigators. We sent our parents to the navigators, which were down the street, had the navigators for the Insurance Affordable Care Act come in and spend a day or so in the office helping parents fill out the forms. We've done that. So in essence, what I've done is acted as a community resource. I don't just give shots. I don't just treat a sore throat. If a mom comes in and says, I don't understand this form the school has given me, can you help me? I'll take a moment in time. Let's see what's going on. Who's doing what with whom? So I think primarily I've just tried to be the person that I want serving me and my children. So we've tried to be a medical home, not just an office where shots are given. And there's so many others. We can spend the whole day doing this, but I just wanted you to know that.
Beautiful.
So if you don't know about the people's pediatrician, this is the people's pediatrician. And so just to kind of summarize everything that has been said on the panel today, I think that what we're overarchingly saying is that Black women, we need to be heard. We need to be listened to, and we need to actively work on education in terms of providers and implicit bias. We need to actively engage community partners as stakeholders, active stakeholders within their care, their own personal health care. We need doulas who are there, who are within the community, who are acting as those agents for change, who are really guiding us and acting as, I call you all gatekeepers, as gatekeepers and advocacy makers, and promoting human rights in childbirth and a human rights framework within childbirth. We need lactation consultants and of color who are who are going into our communities and who are really talking about not just why it's important to breastfeed, but also around the intergenerational trauma that affects us as to why we may not necessarily be actively breastfeeding right now. We need to talk about the intergenerational trauma around forced sterilization and around family planning. We need to really talk about these institutional frameworks that were not necessarily set up to serve Black and brown people. And so, and only through our collective community consciousness of actively working and listening to one another can we actively change outcomes for Black women and babies. Thank you.
But
Wait, we're not done. Hold on.
got one more question, yeah.
We're trying to listen to Black women, and we're serious about it.
We all want to be heard. Yeah.
Wait a minute. Hold on.
She's on fire.
We are, at this point, because of time, we are actually going to open the floor up to questions.
No. You got Alaina. Alaina has a question.
Oh, I'm sorry. My dear.
Your question. Read a question.
Lord mercy. All right. So Alaina, my dear.
Her question is very important.
That's why, you know? Why is it important for Black women to be in leadership positions for maternal and child health initiatives? Cece, you gonna sum it up? Go ahead.
Well, thank you for the question and for seeing me. I first wanted to start out to say that this question has two perspectives to it. And Anjanette so eloquently, richly shared earlier. There's the perspective of looking at Black women being given these positions. And then there's the perspective that we have already been in these positions in our rich legacy and history. One thing about me, I am a doula, but I am also a home birth midwife. And in honoring that, I come from a long legacy, as she shared, of the grand midwives. So within the Black community, we were that resource. We were those in the maternal health and child initiatives. But it wasn't called that back then. It was called life. It was called surviving. And it was called doing the best with what we had and making it work, okay? So when I think about Black women being in position, I see that it involves looking at who we are and creating those spaces of exploring that, you know, exploring our purposes. I knew at a certain point that I was called not just to be a doula, but then to go on to be a midwife. And understanding that the history, it shows that there were thousands to numbers of Black midwives and midwives of color in the South. And then because of, as you said, coming in with the white patriarchal manhood and who came in, we were wiped out. And so now, though, history always becomes cyclical. And so we are on the rise again, and we are coming back. And there's an increase of more Black midwifery students. There's more opportunities that are coming forth for us for scholarships, and we're doing a lot of groundwork to bring back what we originally had. You know, before in the set of coming into maybe a system, because we are working outside of the system a lot. We're community-based, like really grassroots. But wanting to come into a system already established, I would have to say that it takes a lot with knowing who you are, knowing the system that you're working with, as well as for those who are establishing the programs, to understand that about us, that we already have a working culture, a working system. So it's not that we're broken or we're coming in with nothing. It's seeing that the Black community already has and has had a rich history and birth culture, and tapping into that, you know, and giving us that space, more or less. And telling the truth, you know, we need the funding support. We do this work off of our hearts. This is heart work. We're servants. You know, majority of us, we're servants. So it's seeing and knowing that when we're coming in, we don't want to come in per se with an agenda to fulfilling these things. We're about filling the agenda of our families. You know, so whatever they present, we makeshift ourselves to become that. We don't get caught in boxes. We don't like to get caught in just mainstream and fulfilling, you know, bringing forth numbers. While that is very important, we're about the quality. My sister, when she's in labor, she's not caring about my degrees, my certifications, or how many rates of numbers I can produce. She's caring about our connection, about looking into each other and seeing that strength and that support. And she's also caring about how I'm treating her family, because that is the also aspect of Black women being in position and power, is that we are not by ourselves. Our Black men are a part of this. Our fathers are a part of this. The family, the whole Black family is what has to be lifted back up and given the honor back to. So she's also caring about how I'm treating them. So yes, that's what I want to say about that Black women being in position, is that we need more sister circles to do this exploring, like what you do, Chanel, for Ancient Song. You didn't just get up and do that. That's something in you rose and said, do it. You didn't need someone's permission. You just went and you did it. And there's so many more of us that are out here that just need the space to come and, yes, let's get together, sisters. Let's talk about it. Or if we want to go into working with the state or the health department, understanding that we're a communal culture people. So when we're coming as sister and family. Those are very high priorities for us.
So you all are making me want to move back to New Jersey. So I was born and raised in Patterson, New Jersey. Come back to Jersey.
Chanel, we're gonna for questions, we're gonna bring Anjanette up there as well. So if they want to ask questions.
Okay, so we are going to go into the Q&A portion. And so what I will do is I will actually walk around and take off my baby belt.
Yeah, we have a few minutes. We'll do a couple of questions.
Speaking about, when we speaking about family and Black family, it's important for us to lift that up, especially as Black women who are mothers. A lot of times we don't feel like we have the space enough to be a mother and to, I bring my children everywhere I go, like everything. Like I will speak on a panel and I will have a child attached to my chest. And I think it's important in that, and also creating spaces where mothers and motherhood and fatherhood, it feels safe, it feels nourishing, and we're supported in those things, right? Because I know for me, I wouldn't be able to do half the work that I would do, or I wouldn't be able to sit here with you right now if it wasn't for my husband home right now watching 5 children.
Yes. Might as well.
And so yes. All right, so I'm going to open the floor to questions.
Okay. Would you please define the difference between a doula and a midwife?
Oh.
Sure.
Since she's both.
Yes. So as far as being a doula, I am able to do physical comfort measures. I'm able to do emotional support, and I'm able to do labor support. I can do as well as supporting the rest of the family, whether that be childcare or coming postpartum for your home, and breastfeeding education. So anything non-medical, I'm able to do as a doula. And I have to again be specific here, because the definition of a doula has been defined, if you will, by I have to say some white standards of what doulas are like, and that doesn't necessarily fit for our community, because our mothers, our Black mothers, sometimes if you need to be a little more hands-on than what the doula description has been created as. So it helps for me to teach the sisters that work with me. They know how to do blood pressures. They know how to do things that are not necessarily so medical, because they need to be able to give that mom a blood pressure check, especially postpartum, to see if she's okay, or even during pregnancy for preeclampsia or checking for other things. So I would have to say that the specific dividing line is for the midwife. I am actually doing the prenatal care, meaning I am taking her vitals, I am listening to fetal heart tones. I'm doing fundal measurements to make sure that she is measuring according to her pregnancy in gestation. You know, whereas the doula, she's not going to be doing those types of hands-on things. She is listening, she is encouraging that mama during the pregnancy, and encouraging the father and the family, but she would not be doing those things. But we would work hand in hand together. So where I'm doing those medical interventions and so forth, and obviously at the labor, while she is helping mom with positions and getting baby down and getting baby into position, I am there observing. Believe it or not, many good midwives, we're not touching, we're hands off. We're somewhere sitting and we're watching and we're in tune, but we're just really giving mama that space to go ahead and labor and do as God created her to do.
And catch that baby.
And then, of course, yes, you catch the baby, but also dad or other family member, because in some cultures, grandmom is the one who catches the baby, but definitely dad or whoever that the family deems should be. Or mom herself. So again, that is our support at that point as far as catching the baby, and then following through to make sure baby is adjusting well, neonatally too, now being earth side as we call it, and mom as well is doing well, adjusting postpartum, immediate postpartum. And then the doula, she helps out with that as well, because she is, you know, if I need extra hands, I need extra eyes and watching, hey, how's mom, her bleeding going? We want to watch that. How mom needs some food. That doula is getting that, you know, so we work very well as a team. So that is the difference. Did I answer that? It's more.
No, because you're trying to observe for if there's any problem. I mean, you have to really observe the patient for problem. And we also trying to give massages. I mean, the midwives can put their hands on. You can massage. You can tell. You can do everything comfortable. We're using comfort measures more to it than anything else. Yeah, midwives, you have to touch.
All right, so we have a question right here.
Hi, I can talk about that. That's okay. So with regards to the doula scope of practice in like a hospital setting, for a non-woman of color or for a doula of color supporting a mother who's Black, if we witness an injustice happening either socially or medically, what steps can we take and still protect the scope of practice and not compromise the relationship with care providers as a doula to protect the mother's birth experience and protect the rights, but also step in within our scope of practice to make sure that she's being treated well? Is that clear? I don't always speak clearly.
One of the main things is, again, you gotta listen. So you hear, first you have to identify something's going on. And then you start to go back into that navigation system. Okay, if these things do come up, how do we handle it? First is kind of stay calm if you can, but have a conversation. Say, hey, listen, I'm not trying to step on toes, but she has a voice. She's not comfortable. You start with that. Take it from there. It's a step-by-step process.
Start with
prior to the experience in a hospital setting where the doula is there giving support.
Yes.
Where the doula is giving support, say in a hospital setting. By the way, hospitals in the process of giving birth in a hospital was for the convenience of a physician. It was not for the convenience of the mother. So my question is, what policies are in place prior to going into that situation? At what point are those policies identified? Because I find a lot of times if you approach the nursing staff or whomever is in charge, I'm not in OB, so, but I know you have to talk to somebody, establish beforehand what their expectation is and what you want from this experience. Is there a process where that is done and respected? I'm just curious. I would love to know.
What we, and when I say we, I mean myself and other sisters who work for me, who are actually labor and delivery nurses, that we actually talk about navigating the system. And so what we've learned to do is do a lot of pre-relational work. It really helps to build relationships beforehand. So when we know that a lot of our mothers are coming from or going to specific OBs, midwives, or specific hospitals, we make sure to make our presence, whether it's going on a tour ahead of time, so then they get to know our face. We go with them to their appointments, of course, so they're getting us at that point. And then we always send them something special, like some good treats, some good, everyone loves the coffee or the fruit or something, and the donuts, with the signature to say, this is who we are, and we're here. And then they're tending to be a lot more softer and understanding when it comes to who we're representing when we're there. And then we're able to say to the family, this is what is happening. You're able to speak up. You can speak to the nurse, or this is nurse so-and-so. She's really good with this, so that helps.
Okay.
Okay, so I just wanted to just say that, as someone who deals with provider and patient relations quite a bit, we have to also remember that the provider is not looking at outcomes the same way the patient is looking at outcomes, right? A provider will see an outcome as long as there is a healthy baby and a healthy person, then all is well, right? The person who is experiencing the birthing experience is looking at it from a different perspective in terms of how do I feel emotionally, physically, right? And then going and emotionally about my birthing experience. And so that's the difference between having a good birth outcome and a not so great birth outcome. But it's also making sure that you are building a community, right? Because again, you can't go in, it's like going into someone else's house and trying to tell them what to do, right? And so you have to be working together as a community and as a birth team, right? And sometimes it is like, I bring donuts, I chocolates, whatever it takes to be able to, build that relationship and continue that relationship so that if an event does come up, then you can go to whoever the supervisor is or whoever the charge nurse is and say, listen, like this is taking place, and we need to try to actively work to address that. So yes.
I wanted to just follow up. I just wanted to agree with everything everybody has said here, that statement, you get more flies with honey, is so true. Like, you have to realize that coming into these spaces, the nurses are overworked. You're coming into a system that dehumanizes everybody within that space. So just a general, how are you feeling? Why don't, I'll do this. Let me go get this. It allows you to be more respected by the nursing staff. They get to know you when you repeat in the same hospitals, and then you're gaining their trust and a level of authority. Just by even talk about listening, you even need to listen to them. Like sometimes we work with one clinic where a lot of our clients come out of, and just like sitting down and listening to the stories that person wants to tell me, the care provider wants to tell me to unload or whatever. Sometimes that's what it requires as well.
Okay, so we have room for one more question.
She asked it
I don't
earlier.
have a question, but I'm gonna have I have a statement for this lady over here, for the young lady over there, and the doctor over there.
Okay.
So we
My phone's dying.
She's a community doula. As a community doula here in Essex County, we are limited with the number of doulas that we have. So unfortunately, we can only stay, and we try to stay with them until at least they make that 6-week visit, postpartum visit, wellness check, because we try to encourage that. And we're trying to educate our Essex County and our community that we are, that visit is very important. A lot of people connected it to postpartum depression because of the postpartum visit. So that has been changing in the process, and we try to stay, but because we are limited in numbers as of right now, we can only stay with them, but we go to them 2 times after postpartum after they give birth postpartum. And one of them times is about the 6 weeks. That's when we cut them off and we move on to other families.
May I make a suggestion?
Sure.
That you find out who the pediatrician is going to be. Even if you don't get to make that appointment, make your presence known, because I can guarantee you that 90% of the pediatricians of color don't even know you exist.
You're absolutely correct, and we're working on that. I'm coming to you in a few. I'm gonna make sure you are there for that woman. You are there to support that mom. At that moment, when she is giving birth, when she is in pain, when she is going through whatever she is going through at that moment, she doesn't have a voice because she is in too much pain to relay that. So me, personally, I can only speak for what my experience. When they try to come in there with trying to make sure that she signs papers and they're trying to shove something down, trying to get her to sign paperwork that she doesn't understand, that me, myself, and I do not understand, I'm like, give her a minute, please. She needs to make an informed decision. And when she doesn't understand the language, I said she needs a translator here. I don't care whether it's that phone service translator, but she needs to be translated for. So, exactly. She needs to make an informed decision. And it's her decision to make. Not mine, not hers, not everybody else around. Her decision and her family or her husband's decision to make. I'm going to always stand up for that.
Thank you.
For you, Doctor. I'm sorry, but I had to I'm trying to address a couple of people as far as doulas being involved. This is a 1 year we've only been a pilot program for a year, and it's been trial and error for us. But the suggestions here, we're trying to run with them. We're learning. We are trying to learn and partner up with as many people who are willing to accept us. Exactly.
Go to every pediatrician's office and put a piece of bright orange paper in their face with information. Because you see, a lot of times the teenagers come to us first because the parents are insisting that we check them. So, that's a pushback there. You can't demand that. Let me talk to your teenager first before you push anything. So we need to know, so we can call you and say, this is a possibility. We're going to need some intervention. Where can we send her so that she'll get the best information, and we can calm mom down so she's not going to kill my teenager. Okay?
Well, and that's another thing. That's one and final, before I pass the mic on. But I want you to understand, 8 years ago, I was that mother with a teenage daughter at 16 who came home and she was pregnant. I did teach my daughter 3 years prior to that no matter how I would feel, no matter what anger, whatever I was going to go through, that prenatal care was the most important thing that mattered. Not my feelings, not how I felt, not the disappointment, whatever that I was feeling at that time. That wasn't the important. The most important thing was her prenatal care. And with her and her brother, they teamed up to tell me that she was pregnant at 7 weeks. And I swallowed my words. I cried. I did whatever. I boo-hooed. But 2 days later, we were at the gynecologist. She had my grandson, 7 years old today, and I was blessed to be there for that birth. And then after that, she had another one, and I was blessed to be there for that one too. So thank you so much. And I don't have that.
No. Okay,